Yeah, thank you very much for that introduction. And thank you too for the invitation to speak to today's event. And I'm obviously very disappointed that I can't be with you today. I've heard of the Swiss Forum for Primary Care in my previous work, and I very much hope that at some point in the future I'll be able to attend in person. So yes, and these are, I think, exciting times for integrated care in many ways. Over the last decade, we've seen an increased emphasis on the importance of integration, whilst in the past we've generally seen that for vulnerable populations such as homeless people or people with very complex health conditions, there's a need for the different health and social care professionals to work together better. But I think the change that we've had now in terms of our overall thinking is that we recognise that integrated care is a fundamental dynamic across the health and social care system. It's not for the few, but it has to be in place for all of our people who require support for health and social care services. And that's been reflected in developments such as the World Health Organization strategy on person-centred and coordinated care, and also some of the fantastic work done by the European Union. So these are genuinely exciting times. And COVID has obviously been an incredibly difficult time for all of us. But again, I think it's only underlined once again the importance of different parts of the healthcare system, hospital and primary care, and different parts of the wider system, the charitable sector, the personal care and social care providers working together to support individuals and communities. So I'm genuinely delighted to one, talk today, but two, to understand your questions and to respond to those as best I can. So I will just start steering my screen. Good. Thank you. Thank you very much for clarifying my screen share. That's great. Yes. So so Ursula asked me to talk about the difference in approach to integrated care between England and Scotland. And I'll talk a little bit about why that's such an interesting comparison to make. Having given you some brief overviews of how those two countries have sought to encourage better collaboration between their professionals and the services, I'll then share with you some of the emerging evidence of what difference these impacts have made in terms of the experiences of their different populations. We'll then think briefly about COVID-19 and what this has taught us about integrated care in Scotland and England. And then finally, I'll draw back and think about what are the main points of learning for other countries and contexts that are trying to better integrate their health and social care services. In terms of who I am, my background is I initially qualified as a social worker in Edinburgh, and then I worked with a number of different adult populations, including people with mental health difficulties, people with a learning disability, and older people, before moving into management. And I had a particular focus in management in setting up new pilot projects of health and social care integration. I then spent time as a purchaser of health and social care services, but for the last 10 years, I've been an applied academic. My PhD is on managing change in health and social care, and most of my work is looking at the national policy programs around integration for different populations. But perhaps most crucially for this presentation today, I was actually brought up in Scotland and went to school in Scotland and trained in Scotland. But I've spent most of my working life in England and predominantly in the West Midlands around the city of Birmingham, which, as you may know, is a very rich, diverse and multicultural area with all the highs and lows that brings. Okay, so let's start off by thinking through what are the different approaches within England and Scotland regarding integrated care. A brief bit of policy context for you is that in the United Kingdom, many of the functions are undertaken at a UK level. So things such as taxation, issues such as defence, issues such as international diplomacy are undertaken by the Westminster government on behalf of the other four nations. But over recent years, increasingly, the responsibilities of government have been delegated down to the four home nations. So that would be Wales, Northern Ireland, and Scotland alongside England. And that includes responsibilities for matters such as some of their legal functions. It includes responsibility for education, but perhaps most crucially, it relates to responsibility for their health and social care services. And what that means is that we've got a really interesting, almost a natural experiment of health and social care, in which we've got 4 countries who are bound together by many similar traditions. Their populations face many of the similar difficulties in terms of increasing the old populations, continued difficulties with health inequalities, and so on. But within these 4 countries, they have to some degree also brought in new ways of doing things that enables us to consider on a national level what the impact of these national policies have been. As a bit of other broader context, so in terms of their populations, Scotland's population is about 1/10 of the population of England. So it's about just over 5 million people live in Scotland, and about just over 60 million people live in England. Their budgets are kind of similarly different. So in Scotland, the budget is just over 10 million for the NHS. In England, it's just over 100 million in the NHS. The way that their basic units of organisation in the health and social care services are also similar. So both in England and Scotland, healthcare provision is delivered through a national health service that is largely funded through taxation and free at the point of delivery. Whereas social care services, so things like long-term care for people in their own homes, residential care, daycare for vulnerable adults and older people, is funded partly through taxation and administered by a series of local bodies called councils, but also with some aspect of personal contribution from individuals themselves. And that does vary to some extent between England and Scotland. But what that means is that we've got, on the one hand, we've got a national health service organised from central government in terms of England and Scotland. But then for social care, we've got locally organised services with a different level of democracy and a different elected body. So some of the challenges that they both face in terms of trying to encourage health and social care services and professionals to work together come from a similar place. And on top of that, there are challenges in terms of rising healthcare costs, increasing expectations of the population for the type of health and social care services they will receive, and an aging population are also similar. And so for that reason, both England and Scotland, and indeed Wales and Northern Ireland, have all seen integrated care as one of their top priorities for how their system can be more effective. But as we'll see, how they've gone about that is quite different. So let's start and think about Scotland and how Scotland has gone about trying to integrate health and social care. And the current policy initiatives in Scotland regarding integrated care go back to a broader reform of the public sector called the Christie Commission, which happened in 2011. And the Christie Commission looked at public policy in Scotland in general and said there needed to be an overall shift to more preventative services, to better joint work between the public sector, the private sector, and the voluntary sector, for a greater investment in the workforce, and in particular in leadership, and a greater use of digital technology. And the Christie Commission was very influential, and it led to all public sector bodies within Scotland reflecting on what they do and why they do it. So in health and social care, they undertook a number of different town hall sessions up and down the country where they spoke to members of the public, they spoke to local professionals. They also had a pilot program in which they looked to try and explore new innovations in health and social care integration. And that led them to come to the conclusion that they need to do some fundamental reform of how they could bring together health and social care. And their solution to that was to introduce a new piece of legislation called the Public Bodies Joint Working Scotland Act. And what that said was that across the country, the NHS trusts who are responsible for healthcare services and the local authorities who are responsible for social care services had to set up new bodies called integration joint boards, which would bring together a significant, about 10% or so of the funding, I say 50% or so of the funding of health and social care in order to plan together for the local population. So this was a mandate. This was the national government saying to these local areas, you must put together 50% of your local budget for your out of hospital care and for your social care services and use those together to plan and deliver services for your local population. Alongside that, they developed a set of national outcomes which reflected what people told them was important about health and social care services, and also would look at important activity measures such as the number of people being admitted to hospital, the length of time it took before people were discharged to hospital, the length of time people would spend at home when they were terminally ill, etc. They also in Scotland tried to build in a clear sense of local accountability, where these integrated joint boards would have to produce annual statements of activity and performance and how their money was being spent and any pressures that they had on their financial well-being. So in Scotland, what we have is very much a centrally led approach underpinned by legislation, one particular way of doing things, and that's what led to these new integration authorities being set up and down the country. In England, we had a very different approach. So over the last decade, the integration in England has come from a reform in 2011, which tried to bring in more competition into the English NHS. And we've always had a degree of competition within our healthcare services. So yes, the majority of our clinical healthcare services are funded by public money, but people have also been able to have a choice of which provider they go to for certain procedures. And the coalition government of the time brought in new expectations that would be a greater development of the market in the NHS, so that patients would have more choice over which provider they went to from the private sector, but also the voluntary sector. And also in terms of the funders of healthcare services, they would have a duty to ensure that they considered competition and different providers, indeed competition between NHS providers when they're awarding contracts. Alongside that, in terms of integrated care, the English government were very keen on the idea of innovation and of trying to encourage local areas to do things differently. And then for those areas to be able to compete on a financial basis in terms of getting future business. So they brought in a number of pilot programs within England, the long-term integrated care and support pioneers, which were a number of areas looking at health and social care integration. They brought in pilot programs about integration predominantly between healthcare services, the new models of care program. And they also brought in innovations to do with primary care homes, so general practice and trying to do more collaborative interprofessional projects. So unlike Scotland, where 50% of the budget was brought together in a single budget, which services would be funded from jointly, in England, there was only a relatively small amount, 10% of the funding was put in this single budget called the Integrated Better Care Fund, which was held by local government and then would be awarded to local areas if and when they responded to a number of national objectives in terms of integrated care. So the English approach to integrated care, whilst having a similar set of aspirations, has been much more fragmented in how it's trying to do it. It's been much more based on competition rather than the Scottish approach, which has been much more planned and led by national legislation and national planning. So quite different ways of trying to oversee health and social care and to try and better integrate them. Having said that, what's interesting, I think, is that when we look at what that's led to in terms of innovations, there's actually a lot of similarities between what Scotland and England have introduced to try and better integrate care and to better support collaboration. So one of the things they've looked at is the experience of people in care homes. So for many years, we've recognized that particularly older people, but also people with a learning disability and people with mental health difficulties who live in care homes are amongst the most vulnerable of our population. And there's a number of studies going back over time which show that older people in care homes are much more likely to be admitted to hospital on an emergency basis than the rest of the general population. But despite that, historically, the primary care support and the outreach support from hospital to care homes has actually been quite limited. So one of the areas that both Scotland and England have looked at is what can we do to provide more intensive support to people who live in care homes. A similar initiative or a set of initiatives that they've both been looking at is how can we better connect up primary care with our community assets? So within each community, there are a set of charitable or voluntary organizations which provide incredible support to different people, including people from different minority ethnic groups, in terms of their general well-being, in terms of their addressing social isolation, in terms of providing meaningful activities, etc. And both in Scotland and England, and I'm sure this is to some degree true in Switzerland as well, what we find is that our very skilled general practitioners and primary care nurses are perhaps good at the clinical work within their practice, but they have little insight or connection historically with what goes on outside their practice in terms of the communities. So in both England and Scotland, they brought in different initiatives to try and connect that up better. So for example, social prescribing, in which we have somebody within a practice or a group of practices who understands what's available in the local area and to whom the general practitioner can ask patients to go and see, and then they will then introduce them to those services. We've also got approaches such as local area coordination, in which we have a single person within quite a small population of say 40 to 50,000 who's there as a community access point and to whom people can go directly if they're finding life difficult or they're struggling with something else in their family. And the local area coordination will, rather than rush into providing formal social care services, will instead talk to the person about what is it they want to achieve in their life. They will talk to them about what their informal networks are and how they could support. And they will also help them to identify if there are local voluntary organizations that they can access. And another part of local area coordination, which is really important, is there's quite a strong community development angle. So if a local area coordinator sees a number of people, let's say a number of people from the Bangladeshi community who are socially isolated, then they will proactively work with that community to try and develop a service to support them. So it's not only a navigation service that can connect people up with what's already there, but also a development service that can put in place what is missing. Another important aspect of health and social care in both England and Scotland is trying to improve the care planning that is undertaken with patients, and particularly patients with long-term conditions. And again, we've recognised in both countries for many years, and this is not atypical across the world, that traditionally our planning processes with individual patients was led by the professionals. It was about professional expertise, the professionals were diagnosing what was wrong, recommending what the solution should be. And that clearly has an important role to play. But we also know, particularly when we're looking at people with long-term conditions and trying to address some underlying causes of health, that's not enough. That actually the person themselves has to be very much committed to undertaking changes in their own lifestyle, and also that they have to be able to achieve what they want to achieve in their life. So in both countries, we've had a focus on trying to change that care planning relationship. And one project that's been rolled out in both is the Year of Care. And the Year of Care basically says two things. It says, first of all, that professionals were not always holistic in how they approached individual people, that they were often focused on their conditions. They didn't necessarily take the time or have the skills to understand somebody's broader social context and their broader aspirations. And therefore, the health professionals in terms of their training, but also in terms of the diagnostic and care planning tools that they use, these needs to be changed to be much more about the whole person. But alongside that, it also said that actually patients themselves had to be better prepared for, or differently prepared for, these discussions with professionals. If you're used to always going in to see a doctor or a nurse, and the doctor or nurse very much telling you what to do and what not to do, and you can become very compliant, you become very passive. So part of the Year of Care program was about skilling up and giving patients the confidence and for them to prepare before they went into the discussions with the nurses and the doctors, so that they would bring to the table what they thought was important. So there's been a number of different projects, and Year of Care is one of them, but there's been other ones in terms of care and support planning. And the final thing that we've done in both England and Scotland is we've tried to really strengthen primary care. And we've been very lucky across the UK to have a well-resourced and highly skilled general practitioner workforce. But alongside, but other than primary care nurses, that has generally been the focus, has been the doctor and the nurse. So in both England and Scotland, what we've tried to do is try to open up primary care. So it's also got much more capacity in terms of pharmacy, of physiotherapy, in terms of mental health therapy and mental health support, and indeed in some cases in terms of social workers being part of the primary care team as well. And again, a number of different initiatives to do that, but all with the basic premise that actually primary care is stronger and the support more effective and more person-centered if it's more multi-professional. So what I think's interesting in this is that you've got two very different approaches to how the national governments have tried to encourage stroke mandate integrated care. But actually, when we look at what initiatives have been developed on the ground, these are very similar. There's much more commonality between the initiatives and the different innovations that have been introduced in England and Scotland than there are differences. So what does that mean in terms of progress? So we've both been working in England and Scotland at this for decades, but more laterally over the last 5 years in particular. And what I've done here is I've picked out some of the data that looks at two of the key headline figures that we generally are interested in with integrated health and social care. And that has to do with the emergency admissions to hospital and then the discharge of people from hospital once they are medically fit to be discharged. And I probably just want to underline, these are not the only important measures that matter of integrated care. There's many things to do with people's quality of life in terms of their length of life, in terms of their social inclusion. But actually what we know in the UK and indeed from other countries that I've visited, that these are two of the key areas of interest for national governments, because these relate to the most expensive service, which is hospital care. And also there's a general premise that we don't want people to be in hospital for any longer than they have to, because we know hospital presents risks of infection, of losing independence, and being distant from their family, etc. So what do we know in terms of the impact of these different integrated care initiatives in England and Scotland, and the very similar initiatives that actually have been done on the ground in terms of some of these headline figures? So this first graph that I'm sharing with you here comes from the Vanguard programme. And the Vanguard programme in England introduced a number of new models of integrated care, or encouraged areas to introduce these new models. And the ones of real interest here are the multi-specialty community providers, which were basically this extended general practice, the primary and community services, which try to better connect up acute and primary care, and the enhanced care home projects. And what we have in this diagram here is we have over 4 years of data which is looking at what's called the index of emergency admission, which basically is the rate per population of emergency admissions to hospital. And what we find over these 4 years is this purple line is the people who didn't introduce these 3 types of vanguards. And what we find is that over the 4 years, their index of emergency admission rose quite significantly over those 4 years. Within the multi-specialty community provider vanguards, so the vanguards that were focused on new models of primary care and enhanced care homes, what we see is not that their index of emergency admissions has declined from the starting point, but crucially, it hasn't increased since the starting point. And we can see quite significantly the difference between the multi-specialty community providers and the areas that have not introduced a similar initiative. So what that would suggest, and this is only at this point suggesting, that the multi-specialty community provider interprofessional working in primary care has made a difference to the rate of emergency admissions to hospital. This is a slightly more academic or a more rigorous analysis of a similar issue, which again looked at the rate of hospital admissions in different areas. And what we find here, this is the crucial one. So this looks at the rate of emergency admissions over the first, the second, and the third year of the new Models of Care programme. And then this purple is the entire period of the 3 years. And what you find here in terms of the rate of hospital admission is that for the population-based ones, the ones that the initiatives that looked not just the care homes, but across the general primary care population, there was a decrease in terms of hospital admissions, but that becomes even more so when we look at the care home projects. So what that demonstrates is that if we identify our vulnerable populations who are most at risk of hospital admissions, if we bring together the different disciplines and professionals and we introduce the correct pathways, then what this data highlights is that it can make a significant difference to the rate of hospital admissions for those individuals. And then the final data from England I want to share is this. So there's been a big focus over the last 2 or 3 years on something called delayed transfers of care in England. And delayed transfers of care are basically what people who have been through their hospital treatment, who are medically ready to be discharged, but for whom a relevant community package cannot be provided. And sometimes that's to do with healthcare, but more often than not, it's to do with having a decent social care package which can support them in their own home. And again, this is data over about a decade. And what we find is that over between 2013 and 2016, there was an incredible rise of delayed transfers of care in England. And this was causing real concerns in terms of the disruption it caused to individuals, but also in terms of tying up acute hospital beds in relation to people who are ready to be discharged. And that's when the government brought in the Better Care Fund, which was this targeted fund which said to local areas, you have to integrate care if you want to receive this money, and you have to focus on discharge from hospital. And they brought in schemes such as Discharge to Assess, in which old people would leave hospital, go back to their own home, have intense support from community nurses and from social care providers for the first 4 to 6 weeks, and therefore make a successful resettlement from hospital. And what we see here is that once they brought in these initiatives, these very targeted initiatives, again, we have a notable decrease in terms of delayed transfers of care. So that's more people going home in a timely manner than previously. And the final graph I want to share is from Scotland, which is looking at emergency bed days. So the number of people who are taking up emergency bed days from the older population over time. And this top line here is indicating what was the expected trend. So if we go back before 2008, what was the expected trend in terms of increase of number of people occupying emergency bed days over 65? And then these blue graphs here show the actual bed days. And again, what we can see is that as Scotland has introduced more integrated care initiatives, as it's had this legislative backdrop, we can see that the expected rise in emergency bed days has not been what would have predicted from previous modelling. So again, this is not saying that the level has declined hugely, but what it is saying is that we've managed to stop the rise. We've been able to support more people in their own homes through these integrated care initiatives. So I think there's some early signs that the approach to integration and these local initiatives have actually made a big difference. But it's not all good news in terms of integrated care in England and Scotland. And again, I think it's very interesting when you look at all the national reports on integrated care in the two countries, despite their different starting point, more competition in England, more statutory mandatory requirements in Scotland, they've got to similar points. So what you can find is that there's some really excellent local practices of integrated care in different parts of England and Scotland, and these are tried to be shared through national reports or learning networks, etc. But there's still a real difficulty in terms of getting these local innovations taken on and adopted in other areas. Okay. Second thing is that Scotland in particular has brought in quite an organised set of metrics for understanding health and social care activity and integration. England has many analyses of different activity data, etc. But overall, it's quite hard to get a picture on integrated health and social care in any great detail. Despite the fact that both systems have recognised the importance of engaging members of the public and people with lived experience in how we design integrated care, and also introducing them in terms of the governance arrangements, again, this is not as strong as it could be, with many areas not having really meaningful involvement. There's also been a difficulty. We know that we have to move funding from the hospital sector into primary care and the community sector if we want to maintain people in the community and give them a better quality of life. But again, that seems to have proved very difficult. And indeed, in both countries, the percentage of their healthcare funds that are spent on acute hospitals is actually more 10 years later than it is spent in primary care. So the amount in primary care is greater, but as a percentage of the whole, the amount is lesser. And that's because of the incredible power that hospitals hold, the fact that they are such large institutions, the influence of their clinicians, etc., as well as the increasing rise in health conditions. I mean, it's very difficult to do that. And finally, in both countries, there's been concerns about the ability of local senior leaders to actually oversee integrated care to work differently. And in some cases, we've got leaders who are willing to look at the importance for their system, of to put aside their own organizational interests for the interest of their populations. But actually, that's not always the case. We've also got problems in both countries of turnover of senior people. These are very demanding jobs which require people to think very differently. And therefore, we've got difficulties in terms of consistency of leadership. So again, very different initial approaches, but quite similar when you look at the reports done by national scrutiny bodies of what actually experiences has been. And so then we'll turn briefly to COVID-19, which obviously has been an incredibly tragic and difficult time across the world. But particularly, I think it's fair to say in the UK, where our death rates due to COVID were just really tragic and very difficult for so many people and so many communities. And when we look at COVID and integrated care, there were some things that you could say were COVID actually accelerated. So there was a new urgency in the need for collaborative working. So in those areas that perhaps have been a bit slower in terms of trying to do things differently, the pressure of COVID and the unprecedented demands on health and social care services did lead to some people saying, right, we're going to try and do something differently because of this. There was also, when we went into the first couple of lockdowns, when basically people couldn't go out very much, they were stuck in their own homes, and most formal services were working on a virtual basis or via the phone, we started to more properly recognise the value of community organisations. So those organisations who are often not very well funded, but led by local volunteers who understand the needs of the local populations. And we got lots of good examples that were shared through national media and other routes of local volunteers who were really making a difference to people, who were just getting together, who were calling people on a regular basis, who were taking around food parcels, etc. And also, I think in terms of our vaccine administration, which is one of the things that we have done well, the few things we've done well during COVID, a big part of that is through volunteers, people signing up to go along to help to administer these vaccination clinics and to support the doctors and nurses and to free them up through the clinical time. But as I said, the UK death rates have been much higher than many comparator countries. And what's particularly challenging is that the deaths that we see, there's much more deaths in those populations which are generally excluded. People from minority ethnic communities, people in manual and low paid jobs. Those are the people who have been more likely to suffer from long-term COVID, and also people who are likely to die. So it suggests that we still haven't addressed, despite these many years of integrated care, we still haven't managed to address some of these health inequalities. And a particularly challenging lesson, I think, from England and indeed Scotland regarding COVID was the level of death of people living in care homes. And it's phenomenal when you look at the percentage of people who actually died during the first 6 to 9 months of COVID that were older people in care homes. And we still don't fully understand why that's the case in the UK. And indeed, this has been mirrored in other parts of the world as well. But in England, one of the particular difficulties seemed to be that the NHS initially focused on itself, that it focused on protecting hospitals, and we understand why it's important in COVID to do that, but it protected hospitals at the cost of people living in care homes. And what that looked like was people were being discharged from hospital without being tested for COVID. Yep. People who were working in care homes did not get the correct protective equipment. Now, that was sorted out over time, but initially what we saw in this time of crisis was the health service retreated and focused in on itself and did not think of its colleagues and these vulnerable people living in care homes. And in Scotland, that was less the case, but there were still real challenges in terms of the support for care homes. And that relates to the fact that the people who work in care homes are badly paid. They often have to have a number of jobs, so they work across a number of different care homes in order to get a sufficiently decent income. And what that means is that you had people who are working in care home A one day and care home B in another day, and therefore they could transmit the COVID infection. In both countries, what they identified was that they just didn't really understand the care home sector. So care homes in both England and Scotland are provided largely by private sector organisations, some by voluntary, a few by the local authorities, but they just didn't really understand how the market worked. And they couldn't really coordinate the market because they didn't have the intelligence, the communication in place. So this demonstrates that even though we've had a focus on care homes and we've got some fantastic examples of multi-professional support for care homes, we still don't fully recognise them at present within our health and social care system at the same level of investment and infrastructure that we do within our hospital settings. So to conclude then, and I look forward to your many thoughts on this, when we look at difference of approach, in Scotland, initially it was about collaboration. It was about using legal duties to mandate different agencies to work together. And it was about pooling a significant 50% of the funding within health and social care was brought together so that could be jointly used to fund services. And they also had a much more sustained approach and vision. In England, it's been much more of a market approach, so much more competition between providers, new innovations, introducing these into the market and then seeing if these would be bought by the local purchasers, limited a pool budget and a continual changing of approach and legal structures. But having said that, there's some learning that we can take from both of them. The first is that if we have a good set of national outcomes, if we have data that explains how we're performing against those, and we tie in incentives both in terms of kind of general performance and in terms of finance, this can encourage local collaboration. I don't think it tells us that competition can never be part of integrated care, but we have to use that cautiously. Competition as the underlying dynamic is very unhealthy for integrated care, so we have to be very cautious. When we think about integrated care, we can't just think about funding for healthcare services, although we do need to think about that. We also have to think about social care, both social care providers and also the voluntary community and sector. Integrated care is about professionals working together differently. So it is about doctors, nurses, social workers, psychologists doing things different, being much more collaborative. But it's not just about them. it's also about the people who manage those services. Okay, those people who have oversight of the resources, it's about them working together. And it's also about their senior leaders being able to step outside their organizations and to think about the needs of their systems. And that sometimes they have to sacrifice the interests of their own organization for the greater good. And finally, it's also about politicians and policymakers. They have to be willing to take responsibility for some of those tough decisions of funding and how funding is allocated to better integrated care. And the final point is just that integrated care, and we know this, it's not a quick fix. You have to give integrated care time to develop, to build. You have to look at what's going well. You have to look at your data, what's not going so well, and respond accordingly. But what you can't do is you can't keep chopping and changing, going different directions, because that just disrupts people and doesn't give you the learning. So finally, where are we going next? So, well, England, I think, has learned this lesson and is now moving away from competition. And we're bringing in something called integrated care systems, which are not dissimilar to integration authorities in Scotland, but actually work on a greater population, up to kind of 5 million people, and also include hospitals and hospital services, which is very important. In Scotland, they have finally reviewed. Undertaken a major review of their social care services and thought about what do we need to properly fund and resource and organise the social care sector in Scotland. And we're just waiting to see what the response the Scottish Government will be to that. In England, we've had numerous reviews, numerous policy papers on this, but we've still not made a decision. But the government have promised by the end of this year there will be something in place. So please keep your fingers crossed that will happen. If you want to know more about England and Scotland, and indeed integrated care in other countries in the world, the International Journal of Integrated Care will be publishing a series of papers over the next 6 months in which we brought together policy and academic experts from different countries, and that includes England and Scotland, to publish their reflections of 10 years of integrated care and what can be learned from their initiatives and their challenges. So do keep an eye on those, and they'll be coming out over the next 6 months. And finally, that's me. I'll answer your questions now, but I genuinely would like to keep in contact with you. If you get any questions, my email's there, my Twitter's there. It'd be a pleasure to continue the debate and to understand what your learning is as well. So thank you very much.
And now the sun is shining on your face. Isn't that nice?
It is. It's a sunny
Thank you very
day,
much, Robin Miller. We have a wonderful day here in Zurich. I hope it's the same in Birmingham. And thanks for this insight, sharing with us the experiences. We have several questions. Ich habe Ihnen vergessen zu sagen, aber Sie haben es ja selber gemerkt, dass Sie natürlich auch upvoten können. Das heißt, wenn Sie eine Frage gut finden, geben Sie einfach ein Zeichen und dann rutscht diese Frage nach oben und wir versuchen uns von oben nach unten zu arbeiten in diesen knapp 10 Minuten. So the first question is from Sandro Berching. We have several people thinking, yeah, that's an important one. And it is about what professional background do you think is important for local coordinators? Sandro says, I would say the social workers would have the most probably coordinating professional skills. Is that the way you see it?
Okay, first, that's an excellent question. And I would certainly agree the social workers have got a very good professional set of competencies to integrate care. So social workers, by their nature, are trained to think about different perspectives of individuals, of family members, of society as a whole. And they're also very skilled in terms of working with conflict and working with dynamics within families and therefore dynamics within teams. So I would absolutely endorse that view that social workers are very well skilled in terms of better integrating care and being part of collaborative teams and potentially being care coordinators. However, 2 things on that. One, I don't think social workers always recognize that, and for some reason, social workers often their role in a service, how they see themselves, is as being the voice that's different to healthcare, and that's particularly true in a mental health setting, where social workers are often the people that are saying this person should not go to hospital. We need a different approach to what healthcare experts are going to say. So they've got to do something where they're willing to come into the fold and they're willing to be confident about their skills. The other thing is it just can't be social workers. So I think one thing that really worries me a little bit is when what we say is we've got a set of different professionals and they're not really working well together. So we'll bring in somebody else on top of them who will coordinate their care. And yes, that might be a necessity for people with very complex needs, but actually what we need is we need those other professionals to be able to collaborate better as well. So this can't just be a question of doctors and nurses saying, well, that's not my role. That's the care coordinator, whether it's a social worker or somebody else. It is their role. And personally, I'm a great advocate that we shouldn't be allowing people to practice in any profession with the health and social care unless they are able to collaborate with their professional colleagues and to work as part of a team. So it's a partial yes for me, but only a partial yes, because actually I think what we need to do is we need to fundamentally say to all our professionals, if you're going to work in these fields, you have to be able to collaborate.
Thanks very much for this first answer. Mathis Brauchbar is asking, what is the experience with social prescribing? How successful is it? And what are the challenges? I mean, it's actually 3 questions, but I assume you can do it in one.
I can do it one. Yes. So no, it's a great question. And there's certainly a lot of expectation for social prescribing and how that's going to enable people to access the community. Now, and I think, so a little bit of a digression, first of all, if I may, in terms of social prescribing. So I do think it's good that we've got this new initiative, but there is something about it that's interesting, I think, is that, for many years, we've had social care services, and a lot of social workers and social care professionals' role is about connecting people up with local resources and trying to include them in society. We've also got a number of community and voluntary sectors who, again, their role is trying to help and signpost people to what would be available in the local community. And it bothers me a little bit that the way that we think we have to address this is by bringing in a social prescriber that is part of the clinical healthcare team. And it just bothers me a little bit that sometimes what you get with integrated care is that you get different professions will say, well, we'll work together, but so long as we're the ones in charge. And there is a little bit of me that worries with social prescribing. Why is it social prescribing? Why do we have to have that medical terminology around it? But I'll put that aside. The basic notion of having somebody within general practice who's able to connect people up with communities is definitely good. And what we're finding so far is that there's definitely emerging evidence. The social prescribing can improve people's well-being. It can decrease their isolation. It can increase their social contacts. It can also, because it often enables people to then go into volunteering themselves, increase their sense of value in society. I think it's still too early to say, does social prescribing lead to decreased hospital admissions, and does it lead to, for example, a longer life, etc. So I don't think we know that as yet. In terms of when it works and when it doesn't work, well, one of the reasons when it works is when it's properly resourced. Sometimes what I've seen is an unrealistic aspiration about an expectation about what a single social prescriber can do within a local area. So we have to make sure they're resourced properly. We also have to acknowledge the fact these are skilled jobs. The people need time to go out in their community and to find out what's going on, and that has to be part of their capacity. And the final thing with social prescribing is we have to see them as equal members of the team. We have to enable them to sit round when we have an interdisciplinary discussion amongst the professionals in primary care and talk about what their perspectives are and their viewpoints and their experiences. So in summary, I am hopeful with social prescribing. I think it's really good that we've got it, but we just need to understand how we do it well and how we make sure that it's effective.
Let's try to get another, I would say, probably 2 questions. Unfortunately, we don't have much more time. I would like to take the one from Martin Högs. He said that you said, Robin, sometimes the leaders have to sacrifice the interests of their own institutions for the greater good. And his question is, did you find hints about how this altruistic and necessary attitude can be promoted? I think we could deserve a very good answer there.
Yeah, no, again, and it's a really excellent question. And I think there's a number of different elements to that. I think there's something about the sort of the professional bodies and in terms of national government setting that tone of leadership as being leadership for the system, not just leadership for their organization and for their profession. And it's something about that becoming the norm. The norm into which leaders are socialized has to be systems-based, not individual-based. I think development is an important part of that. For me, I think leadership is a practice similar to any other type of practice in health and social care. And the way that we foster good practice is providing regular opportunities for reflection, for challenge, for peer support, which is based on these principles of thinking about the system, not the individual. And the final thing we can do, and this is a bit more transactional, is that when governments or when funders are identifying what are the incentives for organizations and what are the financial penalties that go alongside that, they have to build in aspects of the system within that. If you say to somebody who's a chief executive of a big trust that their most important thing is maintaining the financial bottom line of their organization, that's what they're going to do, even if sometimes they would be better investing outside their hospital because they'll prevent demand coming in. You have to put in that actually they've got responsibility within their roles and in terms of the penalties and incentives of the organization that responds to that behavior. So you need both ends. You need a kind of a visionary, encouraging, a developmental, but you also need some of the money to talk. And if you look at the Better Care Fund in England, basically what it said to these local areas was, you only get 10% of your budget if you bring together health and social care in order to better discharge from people from hospital. You show that you're making progress in early discharge, and also they had to put money in shoring up the local social care services. And because they did that, that's what the leaders went with. I'm not saying they wouldn't have gone with it in some respects, in some places, but fundamentally, it didn't make any sense for them not to do that because they would lose 10% of the budget. So that's what we need to do. We need both the encouraging, but also some of the sanctions that if you don't behave in that way, this is what will happen.
Like almost everywhere.
Like most things. Yeah.
I would say let's take a last question, knowing that we're running a bit late, but I think one last one, if you maybe can keep the answer, if possible, rather a bit short. It's from Simona de Berardinis, and she asked, should the health professions integrate social work in their professions, in the meaning social work as a new health profession?
Oh, well, that's a very hard one to keep short. There we go.
Last one.
Last way. So yeah, that's an interesting one. So yes, well, yeah, yes and no. I don't think it really matters. Actually, I don't think it really matters whether they're seen as a health professional or a different professional. I think it's more about their professional status being recognised and being seen as being equal. In England, we've tried both. We've tried social work being part of the General Healthcare Professionals Council. We've now got social work as its own regulator in Social Work England. So no, I don't think it necessarily has to be, because then I think what you get is you can have we're health professionals, and social work. So no, I'm not sure it has to be a health professional. I think the main thing is that we see for this equality of esteem between them. But I would love a longer debate about that another time.
Yeah, I would say so. I don't know, Robin, I mean, we have several more questions. So if somebody would send you an email, would that be okay for you?
That would be great. That would be fantastic. I'd be very happy to respond to those.
Okay, also, liebe Gäste, wir sind leider für diesen Teil zu Ende. Thank you very much, Robin, for this, not only for your speech, but also for the Q&A. I think it was very interesting. Following you while thinking and getting a bit into your experience. Und wir machen jetzt hier, we'll have a little break so that you know what we are doing. I don't know if you understand German, so I allow myself.
French a little bit, but yeah.
Alors, on va peut-être faire ça en français, non, mais ça va être terrible pour les traductrices. Ich gehe zurück auf Deutsch und bleibe schön bei Deutsch. Also, wir machen gerne eine kurze Pause bis 10:15 Uhr. Und ich habe es Ihnen zu Beginn der Veranstaltung gesagt, ab jetzt haben Sie immer mindestens 2 oder 3 Optionen parallel, die Sie auswählen können. Und Sie können sich in jede Session neu einwählen, sollen das bitte auch so tun. Und um 10:15 Uhr hier im Hauptteil wird Stephanie Monod so quasi den Ball aufnehmen von Robin Miller, und zwar wird sie uns als Direktorin, der Gesundheitsdirektorin des Kantons Waadt 3 Beispiele aufzeigen, wie sie das zu machen versuchen. Der Kanton Waadt als Kanton, der relativ weit ist, als einer der ganz wenigen in dieser Thematik. Bis dahin aber eine kurze Pause. Um 10:15 Uhr geht's weiter. And again, thank you very much and see you later.
Thank you very much.